Dear audience, I am glad to be the one opening this session. My name is Ioana Creanga-Murariu, and my PhD is about cannabinoids in the landscape of cancer. I am a bilateral PhD student at Grigore T. Popa Medicine and Pharmacy University in Iași, Romania, and here at Semmelweis University. My vision is to improve the quality of life of cancer patients, and the mission is to decrease the disease burden of cancer patients. I have three specific goals that I'm going to present one by one. The first is investigating the safety and efficacy of cannabinoids in cancer patients. As you know, cancer incidence is increasing, however, the mortality seems to be decreasing. So quality of life of survivors is as important as an efficient therapy. Almost 30% of cancer patients admit using cannabinoids, either physician prescribed or illicitly procured. So they raise some issues regarding a proper therapy, indication, and safety. My question is, are cannabinoids safe and more efficient by comparison to standard of care or placebo for the palliation of cancer-related symptoms such as pain, nausea, vomiting, cachexia, mental alterations, or quality of life? We performed a systematic search and 98 articles were eligible. Here you can see the first results for pain, which was assessed in advanced cancer patients, measured with the numerical rating scale with 0 meaning no pain and 10 meaning worst pain. These results come from interventional and observational trials where a comparison between baseline and after intervention values were performed. And we subgrouped the results based on the THC and CBD content of the drugs because these are the active molecules. We found a pooled result of minus 1.2 in pain, with better results for THC predominant drugs. The second outcome is anxiety, measured in the same population using the numerical rating scale, and cannabinoids conducted to an overall decrease in anxiety with 1.3 points, with better results for CBD predominant drugs. Here you can see some results of the side effects. The most important are the psychiatric side effects, with THC predominant drugs users having the 10 times the odds of developing some type of psychiatric side effect. Adding CBD to the THC molecule dropped these odds to 2.6. Here you can see a list with all the side effects, with asthenia and gastrointestinal being the statistically significant. Our study is the first to show clear benefits for pain and anxiety in cancer population. However, the limitations come from the inclusion of studies with high risk of bias and the increased heterogeneity due to the intervention or population. So in conclusion, cannabinoids have benefits for cancer-associated pain and anxiety, however, with considerable side effects which limit their usage in the clinical practice. They should not be prescribed for constipation, depression, fatigue, mobility, or quality of life due to no effect. We should develop high-quality randomized trials where standardized cannabinoids assess the effects for pain and anxiety and explore more their effects for appetite, insomnia, or nausea, because we did find some benefits for that. We need studies which analyze the effects dependent on the THC and CBD ratio, and nevertheless, dose-finding studies. Our article was accepted in current oncology reports. The second project is investigating the antitumor activity of cannabinoids in preclinical model. The antitumor effects of cannabinoids were demonstrated in preclinical studies and were investigated in various cancer models because it has been shown that they can modulate the hallmarks of cancer. So our question is, do cannabinoids have antitumor activity compared to controls in preclinical tumor models? We are going to investigate in vitro and in vivo tumor models that were administered cannabinoids, either alone or with chemo, and we assess the antitumor effect, which means the decrease in tumor cells or tumor volume. After the systematic search, 230 articles were eligible. Here you can see results derived from in vivo glioblastoma tumor models that were administered cannabinoids. They were compared to the vehicle, to animals treated with vehicle, which means a substance that is neutral, and we calculated the mean difference between the baseline and the after values of tumor volume in millimeters square. If we were to apply the RECIST criteria of anti-tumoral drugs response, we would have a partial response. Cannabinoids decrease the tumors with an overall of 980 millimeters square, with better results for THC-rich drugs. In case of breast cancer and lung cancer, we saw the same antitumor activity where animals were compared to the vehicle. We did not see any effects in case of hepatocarcinoma, neither good or bad. When combining cannabinoids with chemotherapy, we did find an additive antitumor effect in case of glioblastoma and breast cancer. However, in case of pancreatic, colon, lung, prostate, or skin cancer, combining cannabinoids with chemotherapy resulted in an increase in tumor size, which was consistent to a protumoral activity, however, not statistically significant. So cannabinoids have antitumor activity for glioblastoma and breast cancer. However, they might exhibit some protumoral features for gastrointestinal, pancreatic, prostate, or skin cancer. The translation for phase 1 clinical studies is feasible only for glioblastoma and breast cancer. Be aware that if you choose to administer cannabinoids for pain and anxiety, they can also modulate the tumor dynamics. So always do a proper anamnesis of your patients with suspicious progressive disease under chemotherapy because they might be taking cannabinoids. In the future, we should develop clear rules for performing high-quality preclinical studies for more objective and less heterogeneous results. We should explore these biphasic effects of cannabinoids and understand the mechanisms behind the pro- and anti-tumoral activity. And nevertheless, we should use standardized cannabinoids for a more predictive response. Our project is currently under the risk of bias assessment. And finally, the third project, investigating the profile of cannabinoids used among cancer patients. Although the legal medical cannabis global market size is more than $13 billion, medical cannabis is not yet FDA approved. So our question is, what are the characteristics of cancer patients consuming cannabinoids, and what are the particularities of cannabinoid administration in cancer patients? Answering these questions will be important because we could prescribe drugs according to the patient's preference, and we can design future studies which support the patient's needs. Our project just passed the feasibility check. So in summary, I have 3 projects. The first is about the symptom control with cannabinoids, the second is about the anti-tumor effect, and the third is the profile of cannabis use among cancer patients. As additional activities, I'm an assistant lecturer at Medical Oncology and Radiotherapy Department at my home university in Iași. I also do preclinical research at the CEMEX laboratory, and my results were presented at various international congresses with very good feedback. Thank you, and do not forget, the harder you work, the more luck you seem to have.
Thank you very much for the presentation. The paper is open for discussion.
Mulțumesc. Which Nobel Prize winner, because we had so many Nobel Prize winners in that video, trained in Iași?
Palade.
Very good.
Palade. Yeah. Thanks for the question.
So I was going to ask you about the use of cannabis in cancer patients. So in most countries, the use of cannabinoids is still considered illicit drugs. So how does this, or these articles that you've used address this issue? Like maybe patients do not even admit that they're using cannabis or
yeah. Of course, that's why we as clinicians must be aware of the side effects because our patient might be taking cannabinoids and we don't know that. An exclusion criteria for our articles were patients that were taking illicitly procured cannabinoids, if that was mentioned in the articles. Mm-hmm. So our articles come from countries where cannabinoids use is regulated and allowed, mostly.
So what are these countries? I think Germany just...
Germany, Spain,
cannabis.
Germany, Spain, Netherlands, United States, Australia also.
So these are large. And in China, I guess it's not legal,
no,
right?
but
so.
I must add another information. CBD, it is the part of the cannabinoids that does not have the drug part in it, and it is available everywhere in Europe. You can also find CBD supplements in the supermarket here in Budapest. And based on our safety profile, that can give also a lot of side effects, not only benefits, as I showed you in anxiety, but also side effects.
The other question I would have is about this antitumor activity. So how can you compare so many tumors? I mean, even like lung cancer or prostate cancer is heterogeneous.
Yeah.
So, and you were comparing like prostate versus like pancreatic cancer as well. So is that a valid comparison?
It was a different analysis based on the tumor type. So every tumor model that was based on pancreatic cancer was analyzed separately as opposed to the lung cancer, for example. Indeed, there is heterogeneity because the tumor models were inducted in various ways, or the tumor cells used for the tumor induction were different. We are comparing oranges and apples. However, if we want a successful phase 1 clinical trial, I think this type of meta-analysis performed in the preclinical part of the studies are feasible to find a pattern, not really a clinical implication.
Thank you very much. Nice presentation. These cannabinoids mainly act through cannabinoid receptor. Do you know other receptors which can be activated or inhibited by cannabinoids? And do you know whether the cancer cells also have these kind of receptors? So can this a direct effect or an indirect effect?
It actually is, and it explains a part of our results with the tumors. For example, CB1 and CB2 receptors are the most known. CB1 receptors are more predominant in the brain and central nervous system, and they bind better with THC-based drugs. That's why we have greater antitumoral effect with THC, which is shown and proved to bind to the CB1 drugs. In the other part, CB2 receptors are mostly found in the viscera, in the peripheral system organs, such as breast. And we did see that CBD, I did not show you, but CBD binding to the CBD2 receptors in the breast modify the tumor dynamics in the sense of antitumoral effect. Of course, there are a lot of other receptors. For example, TVP1 receptor, which is a new target. However, we did not find any studies which explain the relationship with these new receptors and the antitumoral effects.
Thank you for your presentation. I just wanted to ask, did you adjust for dose or did you look into that?
It would have been very interesting to subgroup the results based on dosage. However, one limitation is that in most of the studies, patients titrated the dosages against their own needs. So we don't really know what dosages were administered. Maybe future studies should aim in finding the right dosage of cannabinoids because that could influence the overall effect.
Congratulations. I have two questions. The first one is regarding your first topic, that have you examined the type of cancer regarding the efficacy and the safety?
No. What it was interesting, they mentioned what types of cancer patients were included. However, the results were not divided based on the cancer type. More interesting was for pain that sometimes they divided the results based on the pain type, either bone, neuropathic, or inflammatory pain. However, the results were not, we did not find that many studies to perform a meta-analysis in this direction.
But yes, maybe in the future you can check the stage of the disease regarding
They are all advanced cancer patients, so incurable or metastatic.
And which kind of gastroenterological side effects developed regarding the treatment?
Only the most common side effects, let's say, abdominal pain, nausea, and vomiting, which applies to almost every medication.
Okay. And my last question, because regarding your second topic, you mentioned that cannabinoid can have pro-tumoral activity. How would you explain that? What could be the pathomechanism?
It is mentioned in the literature, this biphasic effect. It depends on the receptor density within that organ and the dosage administered. One theory is that they can modulate the microenvironment of the tumor, which means lymphocytes mostly, and they can have immunomodulatory activity, which can decrease the the activity of lymphocytes and thus have a pro-tumoral effect. This is only one theory, and scientists are exploring this part as we speak.
Thank you.
For those of us who are not used to smoking pot or in the cannabinoid field, can you explain in hemp there are about 5 or 7, depending on what you count, compounds that are medicinally used and active. You refer to THC and CBD, and they have different usage in medicine. Can you explain the difference between the two and what different effects they have in medical use? Because in AIDS patients, for patients who cannot eat, THC is more often employed, CBD for pain. Maybe you can give us a little background on that.
Well, actually, this is the basis of our first meta-analysis. By subgrouping the results based on the THC and CBD, we wanted to find patterns where this type of drug might work and this one might not work. As I shown you, THC is better for pain. However, it has the psychiatric side effects. Adding CBD to the THC, we do have an improvement for pain, but not as much as THC only, but with lower side effects. In case of appetite, you are right, THC predominant drugs had better results. I also have some plots here which I did not plots, some results which I did not present. Here you can see that we found improved benefits, but not statistically significant for appetite, insomnia, and chemotherapy-induced nausea and vomiting. All these were based on the THC action. Although CBD is good, it has lesser potency, however, with lesser side effects. So that's why I believe in future studies we need to find the right ratio between THC and CBD and to balance the benefits and the side effects.
Thank you for your presentation. My question is about the first part where you compared a lot of quality of life results, but those questionnaires might have different scale, or they are disease-specific or generic. Do you think that was a problem, or how you dealt with this?
Yeah, I think in the plots you can see the questionnaires that the assessment was based on. We have the numerical rating scale, the EORTC quality of life scale, the ESAS questionnaire. These are all numerical rating scale, which means some lesser point is no symptom and the highest point is the highest symptom. The idea of our statistician was to convert everything to the numerical rating scale. And he did some type of mathematical calculation, and everything was calculated using the numerical rating scale from 0 to 10.
Thank you.
Thank you.
I have also one question. Regarding the limitations of your first study, you mentioned one of the limitations was including high risk of bias papers. So if you could run the study again, would you exclude these studies?
No, definitely no. I won't exclude any type of study. Most of the studies come from observational data, real-world data. Of course, they have a lot of risk of bias because people were taking any type of CBD predominant drug in any ratio. However, it is important to know the pattern, the direction, even though everything is heterogeneous here.
And could you do subgroup analysis based on the risk of bias assessment?
I've never thought of that. It could be an idea. I will think of that. Thank you.
Thank you.